Good afternoon, dear colleagues. I'm Alexander Kanchev, and I'm a clinical psychiatrist and a first-year PhD student here at the Center for Translational Medicine. The title of my PhD topic is the association between metabolic syndrome and cognitive dysfunctions in schizophrenia. My vision is that I hope in the future schizophrenia will be a manageable condition and will be compatible with a fulfilling life. To achieve my vision, my mission is that I would like to fully elucidate the relationship between metabolism and cognitive dysfunctions in schizophrenia. Related to my PhD topic, we are currently working on two separate projects. In our first project, we are investigating the effect of impaired glucose homeostasis on cognitive functions in schizophrenia. In our second project, we are investigating the association between cognition, visual dysfunctions, and metabolic syndrome in patients with schizophrenia. I would like to introduce you our first project. Some sentences about the background. Schizophrenia is a very severe chronic lifelong psychiatric disorder. The prevalence is around 1%. That means millions affected worldwide in the disease. The prognosis of the disease is very bad. These patients have 20 years shorter lifespan. 25% have a suicide attempt during their life, and they live with impaired functionality and productivity, mainly due to the cognitive dysfunctions. To make the prognosis even worse, these patients are more likely to develop comorbid metabolic diseases and conditions. For example, the prevalence of insulin resistance in this population 2 or 3 times higher than in the general population. And it is really important because diabetes is linked to worse cognitive impairment in schizophrenia, but this has yet not been shown for the beginning stages of the diabetic spectrum, for example, for impaired glucose metabolism or prediabetes. So our aim is to investigate whether the early stages of the diabetic spectrum have an effect on the cognitive functions in patients with schizophrenia. Our clinical question is impaired glucose homeostasis a risk factor of more severe cognitive impairment in patients with schizophrenia? The population is patients with schizophrenia. The exposure is the impaired glucose homeostasis. The comparison is the physiological glucose homeostasis. And the outcome is the cognitive test scores measured by any validated cognitive batteries or test. Our hypothesis is that impaired glucose homeostasis worsens cognitive functions in patients with schizophrenia. If our hypothesis is true, it will have many clinical and research implications. First of all, in the everyday practice, we have to measure all of the glucose homeostasis or metabolism parameters. And if we, for example, the fasting insulin levels, fasting glucose levels, hemoglobin A1C, and if we find any abnormalities or disturbances in these parameters, we have to treat these conditions as soon as possible with every therapeutic option that we have. For example, change the diet of the patients, enhance the physical activity of the patients, and if it's needed, we have to use anti-diabetic drugs as an adjuvant therapy. On this slide, you can see our flowchart of selection and our systematic search. We ended up with 33 eligible full text after the selection process. Here you can see our progress. Right now, we are analyzing our data. And we are looking for different outcomes. We are looking for the standardized mean differences between the cognitive test scores in the diabetic versus non-diabetic group, also in the insulin-resistant versus non-insulin-resistant group, and we would like to perform a correlation analysis between the different glucose metabolism parameters and the cognitive functions. We have some preliminary results. On these forest plots, you can see the comparison in the schizophrenia with diabetes versus schizophrenia without diabetes. To the left from the no effect line, you can see the studies where the control groups, so schizophrenia without diabetes, had the better cognitive functions. And you can see the only study in the right side where the schizophrenia with diabetes group had the better cognitive results. We did not reach the statistical significant result, but it's still clinically relevant because you can see the majority of the studies on the left side. Our meta-analysis will have many strengths and limitations also. We have large sample size, a great number included studies, and this will be the first meta-analysis of the correlations between the glucose metabolism parameters and cognitive functions. And we also have so many limitations it's hard to pull the different cognitive tests together in a meta-analysis, and there are many confounding factors. For example, the medications, the different kind of antidiabetic medications, the different type of antipsychotics. For example, the benzodiazepines could also affect the cognitive performance during the cognitive examination, and the illness severity, the duration of untreated diabetes, the duration of untreated psychosis could also affect the results. And our meta-analysis will be based on observational studies. It's also a limitation. Let me introduce you our second project. As I mentioned before, the cognitive impairment is a hallmark of schizophrenia that is significantly correlated with the functional outcomes. Moreover, schizophrenia appears to be associated with the metabolic syndrome diathesis and is sadly exacerbated by the antipsychotic therapy. And metabolic syndrome and its constituent criteria are risk factors for clinically significant cognitive impairment. So here comes the question in a Hungarian sample: how can we measure the cognitive function of these patients, for example, with the R1 cognitive battery? It consists of 12 subtests that provide 5 individual domain scores for attention, short and long-term memory, for language, and for visual spatial skills. So our aim was to investigate the effect of metabolic syndrome and its components on cognitive functions in patients with schizophrenia. Our clinical question is metabolic syndrome and its components a risk factor of more severe cognitive impairment in patients with schizophrenia? The population is patients with schizophrenia, the exposure is metabolic syndrome and its components, and the outcomes, the cognitive functions, in this case the R1 scores. Our hypothesis was that metabolic syndrome and its components worsen cognitive functions in patients with schizophrenia. If our hypothesis is true, it will have many clinical and research implications. Also, like in the first project, we have to prevent the more severe cognitive impairment in these patients, so if we find any metabolic dysregulations, we have to treat them as soon as possible. Here you can see the characteristics of our sample in our analysis. We analyzed a data set of 155 patients with schizophrenia. 57 patients met the American Heart Association criteria of metabolic syndrome. And I would like to show you some results. You can see the comparison of the socio-demographic and clinical variables in this table. We found statistical significant differences in the BMI and waist-to-hip ratio. It's not a surprising result, but we also measured interleukin-6 levels because it's associated with schizophrenia and with metabolic syndrome also, the chronic low-grade inflammation, and we found significant differences in the interleukin-6 levels. On this slide, you can see the differences between 3 groups. With blue, you can see schizophrenia without metabolic syndrome. With red, you can see schizophrenia with metabolic syndrome. And with green, you can see schizophrenia with metabolic syndrome plus diabetes mellitus. Schizophrenia without metabolic syndrome had the best. That group had the best results on our cognitive function, followed by the schizophrenia with metabolic syndrome. And interestingly, the schizophrenia with metabolic syndrome plus diabetes mellitus had the worst results in the R1 cognitive battery, especially in the attention and the delayed memory domain. After that, we were interested in the differences between the interleukin-6 levels in the 3 groups, and the schizophrenia with metabolic syndrome plus diabetes mellitus had the highest level of interleukin-6, followed by the schizophrenia with metabolic syndrome, and the lowest in the schizophrenia without metabolic syndrome. Interestingly, we did not find any statistical significant differences in the CRP levels. And after that, we were interested in the correlation between the interleukin-6 levels and the cognitive test scores. And at the top of the slide, you can see the correlation between the interleukin-6 levels and between the attention domain scores and the delayed memory scores. And we found a significant correlation in these 2 domains. And yeah, I would like to show that. So what are the conclusions? What are the implications for practice and research? Based on our results, metabolic syndrome worsens cognitive functions in these patients. Type 2 diabetes is the greatest risk factor for more severe cognitive dysfunctions. Metabolic dysregulations must be prevented as soon as possible. And we have to think about schizophrenia as a systemic disease, and multidisciplinary treatment is needed. The implications for research is further studies needed to investigate the interrelationship between metabolism, inflammation, and cognitive dysfunctions in schizophrenia. We started to write our manuscript. There are some ongoing analyses still on our data, but we would like to submit our paper in the summer. And I would like to thank you for your kind attention and finish my presentation with one of my favorite quotes. The key to happiness is not to get more, but to enjoy what we have and fill the empty frame of our lives instead of enlarging it. Thank you.
Thank you, Alex, for the great presentation. My question would be that on your first forest plot, you mentioned that there was outlier. And what do you think, what could be the reason for it?
The short answer, the authors did not know also, but I went through the article, and the control group had very, very bad cognitive results on the Airborne cognitive battery. They had a mean score of 64, which is a really low result because the minimum score on the Airborne is 40, and the maximum score is 160. So the 64 is a really bad result. We see results like that in dementia studies, I think. So yeah, maybe it was the problem because the cognitive test scores, the mean score of the patients with diabetes did not differ from the other studies. The difference was in the control group.
Thank you.
Thank you.
Right, I have a question regarding your second project. It's very interesting that you divided your patients in metabolic syndrome and non-metabolic syndrome. My question is, have you collected data of what kind of antipsychotic medications these patients are taking? Because based on my knowledge, there are some second-generation antipsychotics like clozapine or olanzapine who are associated with weight gain and hyperglycemia and dyslipidemia. That might be associated with metabolic syndrome.
Yeah, we are analyzing the data, but you are right. Yeah, there are some antipsychotics could influence the metabolic parameters of the patients. For example, clozapine and olanzapine is related to weight gain and could affect the glucose metabolism also. So it's an important question, but right now we are analyzing the data.
All right, so you have the data.
Yeah.
That would be great. Thank you.
I have only one question. So in your second study, you showed that patients with metabolic syndrome have worse cognitive performance. And you also mentioned the IL-6, which can be obviously one of the reasons, like the neuroinflammatory mechanism. But in your data set, are you able to measure the exact biological mechanism why those patients have worse performance? Or do you have data like neuroimaging, for instance, or
no? Sadly, we just have these laboratory markers like interleukin-6 and glucose metabolism parameters. So yeah, it's like we just can say it's peripheral inflammation may mediate the relationship between these factors.